Today on the Ever Onward podcast, we have Eric Lyall, MD. He is a doctor that founded Peak Personalized Healthcare in Meridian. Eric is trained as an emergency room doctor who now specializes in longevity and personalized care. With my co-host this month, Andy Scoggin, we are going to dive deep into health, wellness, hormones, cardiovascular disease, cancer prevention, and everything that Eric does in his clinic to try to help increase both health span and lifespan. So please join us today for Dr. Eric Lyall. Welcome, Dr. Eric Lyle.
Thank you for having me.
Incredible physician here with a practice that's in this game that we're talking about, and we're really excited to talk to you. Well, let's start where we were talking. We're talking about Chris Hemsworth. Andy asked me, have I done my genetic testing? And you guys blazed into a great conversation that
Absolutely.
We're going to get into. But talk a little bit about this.
So, and the doctor's going to know a whole lot more about this than I do, but what has come out, just because of the excellent work that's been done over the last 20 years on DNA and on genetic testing, is now they can go through and look at your markers and likelihood for hundreds and hundreds of different aspects of health. And I had that done a year ago, and it tells me whether I'm more likely or less likely to develop new bone material, right? So I'm on the low end of that. But it also tells me if I have higher risks of certain cardiovascular events, and luckily I'm more protective from a DNA standpoint on those. But then it also, there's one section they look at which has become a focus in the mental health world of this APOE gene. And there is a variant that's 2, a 3, or a 4, as I understand it. And if you have and you get one from mom and one from dad. So I get a APOE from mom, APOE from dad. If they both gave me a 2, I'm actually lower statistically likely to have Alzheimer's onset throughout my life with a 2 than with a 3. 3 is fairly neutral. So if you have 2, that's great. You're really protected. 2, 3, you're still fairly lower than the average person in terms of likelihood. 3, about neutral. Add 1, 4 in there, and so now 3, 4, and I'm slightly above average from the U.S. population, at least, maybe world population. And then a 4, 4 significantly boosts your risk of Alzheimer's. Now, having said that, you're still not destined to receive it, but what it does is it gives you this idea that, okay, I've got to be more focused on. In an earlier podcast, Tommy and I talked about insulin and all the stuff we're learning about. I've got to be more thoughtful about my glycogen intake. I've got to be more thoughtful about my movement and all brain health. So brain health, all the things that are I should be focused on anyway. But if I know I've got a slightly elevated risk, I'm going to
be more
know how to build a lifetime focus that's going to say, well, that'd be great, but if you reduce your alcohol consumption, reduce these other things that may be commonly acceptable, eating a lot of junk food, whatever it is, don't do it. Do a lot less of it, because the impact on you is going to have a bigger negative result than somebody who's in the middle.
The genetics might load the gun. But then it's the rest of the stuff that pulls the trigger.
It makes sense, right? And there was some, a little bit of contention with some of these testings, like, do you want to know this if there's nothing you can do about it? But with this, there's certainly something you can do about it, right?
Exactly.
And
the BRAC, which is
the
likelihood of breast cancer development.
Totally.
Great to know early on if you can take, actions to prevent. So
and it's one of those things like
this.
With, discussing with patients, figuring out what their goals are too, and have that shared discussion of like, hey, do you want to know some of these things? Some people don't want to know, like, hey, am I going to have a higher risk of dementia? But a lot of people do, and want to know, hey, what can I do to help prevent that? Some things being simple, some things being lifestyle oriented, some things being pharmacologic in origin. But having that data, having that knowledge, I think is powerful. Empowers people. So
I think that we should, at least for me, you guys know each other, but I'd love to know a little bit about the practice.
And I think it was a good place to start, because what we want to get in with you and that's why I wanted to capture it, is
Yeah.
there's been so much advancement in how we can learn more about us, how we metabolize, what our genetic factors are, that may influence our lifestyle. So I'm glad we captured that. But yes, Andy. Eric, let's hear a little bit about you and your practice, and then we'll get into the meat of this.
Absolutely. So my background is in emergency medicine. I've been in that for about 9 years or so. Over the past 2 to 3 years, I've really found an interest in longevity, precision medicine, and performance type medicine. It's a new field. It's not something that was really taught about, at least when I was in med school. But a lot of new data coming out, a lot of exciting things where we can really deep dive into what makes you you, and not just say, hey, here's the protocol, here's where you fit in. Yep, you get X pharmacotherapy for Y disease process. And so during my time in the emergency room, you kind of see a lot of different things. You come across a lot of presentations that are very similar, a lot of cardiovascular disease, a lot of metabolic syndrome, a lot of obesity that leads to downstream problems. And, based on my assessment of the medical community as it's right now, we're kind of designed, and I'm taking this term from Dr. Attia, who's been a big influence of mine, is medicine 2.0, where we're really good at seeing a problem and coming up with a treatment, but we're not really good at looking ahead and figuring out how to prevent diseases in the long term. And so I found a big interest by following Dr. Attia and kind of jumping on the bandwagon of how do we best optimize patients. And some of this was selfish for myself as well. So, I was in my mid-30s, had our first kid. You start looking into your own health, deep diving. You start to really get a sense of that we're not infinite and that life's going to come to an end, and want to best optimize ourselves. And so I started doing my own biomarkers, deep diving into it as I was looking into Dr. Attia and some of the longevity work he had promoted. Noticing that my LDL particles and LDL-C was high, my ApoB has been high, my calcium score was not 0, my hemoglobin A1C was 5.6, bordering on prediabetes, and started noticing myself just being unhealthy. And part of that is coming out of residency, getting into the emergency department, shift work, working hard, marriage, kids, etc., life.
Grab food as you can,
grab
sleep as
exactly.
you can, grab these things. They're not.
Yeah, exactly. And so, this insight of, looking into my own biomarkers, looking into my own health, in conjunction with the recent climate of a lot more data out there from the longevity side of things, in combination also with seeing what comes into the ER and what is the common denominator for what leads people to chronic disease, led me on this journey to developing peak personalized healthcare, where our goal is to deliver precision medicine and deep dive into what makes you you to help you optimize to live the longest, best, healthiest life possible. And that doesn't mean you're living to 120. That means that you're living the best life possible, whether that's to 85, 95, 100, great. But really helping people optimize. And so that was a very long-winded and circuitous way of getting to my point there, but that's kind of my background.
So what do you do when I call you up and I say, hey, I'd love to come in, become a patient? What does that mean?
Hey, I'll tell you. You don't know this.
I want to.
He was coming on this week, and I said, so I called his front office, and I said, hey, I'm going to come do a patient intake. So I went in Wednesday and spent an hour and 15 minutes with him, and it was awesome.
Yeah.
It was awesome.
I'm glad to hear it.
Because instead of like the typical thing, right, which is it's medicine 2.0, right?
Yeah.
Well, are you having a problem right now? No.
Mm-hmm.
Take your blood pressure.
Take
your pulse. You're living. You're what?
Yeah. We'll message you with your,
See you in
your
a
labs, like thumbs up emoji.
Yeah.
See you in a year.
It was awesome. He went through systematically with me, and you can talk through your process, but he went through, cancer screening.
Yeah.
We talked about the importance of that. We talked about cardiovascular health a lot because of my problems I've had.
Yeah.
Medications, like he asked the simple question to me. I should know better, but have you had any testing done to look at these risk factors you may have, to look at about how you should be treating and optimizing your health for you, kind of this medicine for you thing?
Yeah.
And I said, no, I haven't had any of that. So I think the difference is stark. I'll let you finish up. But it was an hour and 15 minutes. And the end of it, I just called Chad. I'm like, this was awesome. I needed to do this a long time ago, and it's right here. Now, I think a lot of places around the country, you mentioned you went back. Did you go to the Mayo Clinic?
I didn't. I was actually up in upstate, or just outside Manhattan. I was in just north of the city.
Okay.
There was a white Plains has a huge, for whatever reason, concentration of these really advanced medical clinics and
so they
work.
call them executive medicine programs, executive physicals. And I've been wanting to go for a couple of years to the Mayo Clinic and kind of do all this thing.
Right.
In fact, we almost went last year, Ryan Cleverly and I. We looked it up. We said, hey, let's schedule it together. Mike Boren had just gone and done it with Joan.
Yep.
He spoke very highly of it. I knew you had gone. So I was looking at this, and then I'm like, this is right here, like literally right here.
I don't want to fly to New York or Minnesota. I want to come to somebody that I'm going to know.
Right,
that I'm
to be able
not
to
on a
follow
Zoom
along.
call
Yeah.
if I have a question later on, but I can actually go up. So I love that this is finally we're big enough and sophisticated enough of a city that someone like you can build a practice that really shifts from how do we, just treat a problem that's been building for 10 years to how do we get 10 years ahead of a problem.
Exactly. Yeah, that's what we've noticed as well is, LA, New York, Atlanta, big cities, Houston, Dallas. There are places that, focus on longevity or full concierge medicine. We're really deep diving, going off the standard path, if you will. But the Treasure Valley and Boise and Idaho in general, it's pretty lacking. We're pretty early on. This is something that's been a growing field over maybe the past 10 years, but really 5. And so we're in its infancy. And so there's a lot of places that pop up, that'll put a shingle out there and maybe, deep dive into a little bit of it, but maybe not do the full, really get into it fully. But, our goal was to really bring this to the Valley so people aren't having to fly to New York to get things done like that. So we actually have a client in the Sun Valley area that would fly to LA once a year to do it. And it's
a lot of people
have
and have wanted this here, so it's phenomenal. So from a testing standpoint, things like what are the things that you can do here? Yeah. And you talked about the CAC score, which is this calcium score that we can get for our cardiovascular system. DEXA is a protocol where you can look at muscle and bone density and things like that. Are you doing all of those kinds of things here?
Yeah, we are. So I'll kind of give you a brief rundown and I'll go through.
Love it.
We have like 6 main principles. There's more than that, but trying to consolidate it down to a couple. And so of those 6, we'll start from the top. So the biggest one will be cardiovascular disease, and we kind of already talked about that a little bit. Number 1 killer of Americans and people nationwide. Cancer starts catching up in the 7th decade or so. But really at this point, other than testing your LDL cholesterol once a year over 35, we're not really doing too much from a preventive standpoint in Medicine 2.0 model. And so our mission really is to deep dive into this, partly into what makes you you. So some of the genetic side of things, but also just basic biomarkers. And so we look at ApoB. Apolipoprotein B is a protein that lives in basically a phospholipid layer that carries all your cholesterol around in your blood. Cholesterol can't just float around your blood freely, so it needs to have something to carry it. And so this ApoB is basically a count of how many particles are floating around in your bloodstream at any given time that has the potential to cause atherosclerosis or plaque building up in your arteries.
So is that what some people refer to as soft plaque?
Yes and no. That does form soft plaque, which can then lead to hard plaque, depending on...
Right, because the hard plaque is generally the one, like you said, the CAC 0 score. That's looking at your hard plaque.
Yeah.
That's really hardened around, and where that scores. What is harder to see, as I understand it, is that soft plaque,
correct,
which can be more deadly. And so we really ought to be looking at that. And your normal annual physical is not going to see it, but Peak is going to try to get into that side of things.
Yeah, so your ApoB is one of those measures that's not going to, your level of ApoB doesn't tell you what your soft plaque burden is. That's not the test for that, but that gives you a sense of what your current risk is currently, or what your risk is currently. So ApoB is a modifiable risk factor, similar to your LDL cholesterol, which would be in a standard panel, but it really is a measure of how many atherogenic or how many particles are floating around that are at risk of causing cardiovascular disease for you. So it's better than your LDL cholesterol. So we look at that, basic blood test, comes back quick. We look at Lp(a) as well, another protein that lives on your LDL cholesterol that is more inflammatory, is more likely to cause vascular disease and lead to heart attacks and strokes. That's kind of what a test you can do once every couple of years. If you're integrating management, you want to test a little bit more often, but it's kind of your genetic set point. So we use that along with your family history to really get a sense of what your actual risk is of cardiovascular disease. So less modifiable, very important. At least should be measured once in your life. We measure it more than that, but and then we start integrating, imaging as well. So calcium scoring for people under 50, under 55, a calcium score, no cardiovascular disease history is a good place to start. Calcium scoring is a low-dose CT scan where we look at your heart vessels, and it basically is just looking for calcium buildup in your arteries, which doesn't tell you the whole story. There is soft plaque that calcium score can't see, but it gives you a good baseline. If the calcium score is 0, you're relatively low risk.
And those are an age-adjusted score too, aren't they? The CAC scores.
Yeah.
So a 0 for me at 64 is going to be different than a 0 for somebody at 40. So it sort of allows for a little bit more. That's my understanding.
Yeah, that's my understanding as well. I don't know the exact data on that, so don't quote me on it. But,
but we want a 0. I guess that's the bottom
0
line.
is the goal.
We want a 0.
0 is the goal. And, having a positive score.
I've been 0 since I was like 15, I don't think.
Right. That's what, my own mom is like 1,400. So there's a huge spectrum here. And calcium doesn't mean you have a high-risk plaque that's going to lead to rupture or lead to heart attack necessarily.
Right. But you want to know.
So we integrate, basic biomarkers like Lp(a), like ApoB with calcium scoring, develop a risk profile. We also integrate more advanced testing. We do a Boston heart test for cardiovascular disease to really deep dive into whether you're a producer or absorber of cholesterol, and that can help guide treatment if you're a candidate based on your ApoB, based on your calcium score, et cetera. And then there's also CT angiography of the coronary arteries that can be really helpful as well. Look at your soft plaque. There's some really exciting AI-driven analyses that are coming out. There's a Clearly scan, which is just a post-processing of your CTA coronary. That's really cool. To my knowledge, there's nowhere in the Treasure Valley that offers that yet, but I got to imagine it's right around the corner because the technology for doing the CTA coronary is there. It's just a post-processing. But we get a good sense of what your soft plaque burden is. We can track that over time. It's not a zero-risk imaging test. It requires slowing your heart rate down. It requires contrast. And so we use it diligently. We don't just give everybody a CTA coronary. We use a risk profile to stratify you and put you in a, high, medium, low risk and decide whether or not we do that advanced imaging then. Mm-hmm. And then there's other genetic tests like you had alluded to prior that can give you a sense of whether your cardiovascular disease risk profile is high or low. That's a little bit more advanced. We'll do that occasionally for people. Different single nucleotide polymorphisms, or what we call SNPs of the genetic code, can put you at higher risk or lower risk. And similarly for atrial fibrillation, stuff like that. So a long-winded answer of saying cardiovascular disease is number 1 for us. That's where we really deep dive for people. Number 2, and equally as important, would be metabolic health. Interrelated significantly. So having a high fasting insulin or high fasting glucose or hemoglobin A1C, which is a 3-month average of your glucose, really can affect your lipidology or your lipid makeup as well, your vascular health, your risk for heart attack, your risk for dementia, risk for stroke, et cetera. And so, while we're looking into your cardiovascular health, we're also making sure that your metabolic health's in line because if someone comes in with a high cholesterol, high ApoB, but let's say that their Lp(a) is low and their overall family history is low, but their insulin is through the roof and their hemoglobin A1C is through the roof, there's no real point to put them on cholesterol medication at this point until we get the metabolic health in line. So they kind of interplay pretty significantly. But we look into your metabolic health with biomarkers, so your insulin, your hemoglobin A1C, your fasting glucose, but also your DEXA imaging. So we do have a DEXA scan.
Maybe tell people who don't know what a DEXA scan is, what that does.
So DEXA scan, what it stands for is dual energy X-ray absorptometry. And classically, it's been around for a long time. Classically, it was around for osteopenia and osteoporosis evaluation, predominantly covered by insurance for postmenopausal females. With better post-processing technology, we're able to really delineate your bone from your fat, from your muscle, based on the different weights of absorption at the plate, of the X-ray plate. And so what we use it for primarily at this point is for your metabolic health and your body composition. So we can really track your muscle mass, your fat mass, your fat that we care about the most, the visceral fat around your internal organs. At the same time, we're looking at your bone health. And so we track that very often while we're managing your metabolic health to make sure, hey, if our visceral fat is high, that puts you at higher risk for inflammation, for fatty liver disease, for atherosclerosis or cardiovascular disease. And so we'll do our best to mitigate that risk by lowering that, getting our metabolic house in order before we start hammering medications for a cardiovascular disease standpoint, unless you're very high risk, super high calcium score, or high risk plaque on your CTA coronary, et cetera. But those two interplay pretty closely. So,
And you have
not to interrupt you, but think about the difference in this, medicine, 1.0, 2.0, and what we're talking about here for even what I have as a physician and haven't done that.
Yeah.
It's almost embarrassing. It's like, why wouldn't you want to know all of that data so that you're optimizing treatment? Yeah. It's just so much better.
Yeah. I mean, it's we fully believe that what gets measured gets managed. And having that data.
And I want to get to that with you too, because now you've talked about this extensive testing that most people don't get,
right?
But can be valuable to every one of us. But now you've got all this data on me. If I'm a patient, now do you create a sort of personalized
approach,
program for me? Do we go back and measure it, just come back once a year and I'll see it? Do you talk to people during the year? What is it like to work with you?
Yeah. So we, our goal is to be as high touch as possible. So we think that once a year kind of touch point, hey, try some lifestyle stuff here. Here's a handout on how to lose weight or how to strengthen. I mean, that's unfortunately, that's just what gets lost with Medicine 2.0. I mean, I think what we've built or what we've, started building at this point is what most doctors would want out of their practice, really high touch point, really advanced diagnostics. Unfortunately, the healthcare system is a difficult place. So a lot of patients, very few doctors or APPs and physicians, very little time for those interactions. Insurance coverage dictates, one annual screening physical a year, sick visits, et cetera. But our whole goal is to be as high touch point as possible. And so with what we've talked about thus far with the cardiovascular disease and metabolic health, we're getting touch points on those generally quarterly. So from a metabolic standpoint, if we have high visceral fat or hemoglobin A1C, average glucose is a little bit higher than we'd like. We talk about interventions, whether nutrition, strength training, zone 2, which we haven't really gotten into yet, but and then and or pharmacotherapy or medications if need be. And then our goal is to recheck that in 3 months or so. You can do it more often than if you'd like. However, a couple months is necessary to really make some meaningful change. So our whole point, our whole goal, I should say, is to really be as high touch as possible. And so we do have systems in place where we can do kind of an executive physical where we do a lot of the stuff we've talked about, plus what we'll get into moving forward as a one-off assessment. But our main goal and where we think the most benefit comes from is that high touch point, kind of month-to-month or at least quarterly assessments where we're really checking in on you, integrating a personalized plan, seeing if that's working, more frequently than once a year. And then if it is working, great, we continue the plan. If it's not, let's pivot, let's talk about alternatives, et cetera. But yeah, that's how we integrate it.
Can I say one more thing?
Yeah,
I think, I'm just thinking some of these things are hard, right? Because change is hard.
Yeah.
And depending on where you are in your life and, I feel sorry sometimes for people where you say, oh yeah, you've got a metabolic problem, you got all this risk, here's a handout, Go figure out how to lose 30 pounds and work out 5 times a week. And here's some medicine. Yeah. And we'll see you when you need us next. Yeah. That may be in a year when I get my physical or when I have a problem, I'm coming back. And that's kind of the way it is. Yeah. This idea of measuring things and then having accountability with a healthcare professional that's into your health and following you, that is 3.0. Yeah. Totally agree. Now, I'm sitting here thinking just in society, with the pressures that are currently on the healthcare system, and we, kind of the lie that was like, hey, if we just go to this, we're going to start paying people for. I think at this point it's a lie. Mm-hmm. If we start paying people for wellness, right? Yeah. And we're going to make this big chance from fee for service to population health. That's going to be this was the panacea. Oh, it's going to change everything. Yeah. And I think now we're into that. However many decades, and we're like, this is really expensive. People are getting older. It's not for a lack of trying.
Right. The idea is good. It's how do you get to the execution, and nobody has figured that out. In fact, if you look at us from 50 years ago to now, metabolic health is not better.
Oh no,
obesity is not better.
No,
you start looking down these markers that you're looking at.
Yeah.
And 50 years down the road, we're worse than we were.
Oh, for
now,
sure.
that's because health is fighting against.
Yeah, all the food that sits in front of us, and our jobs that require us to sit at a computer and life's changed.
So thank goodness for people like you who say, I could either be sitting in this, emergency room of all medicine is emergency medicine. Unfortunately, it's all like, I'll wait till it's
exactly
at the end of the
That's
of
the
the
quote.
worst.
That's the quote of the podcast.
Yeah, totally.
All medicine is that
Right
is kind
now-
of defines healthcare
Well,
now.
it really, especially
right,
especially
and
nowadays.
to be able to get in ahead of it, and for doctors like you to say, it's going to be hard, but let me do that. And I know systems are working. I've been involved with the St. Luke's system. I've been involved with other systems. They want to.
Yeah, right.
But to change it, you have to change three things. You've got to change the system.
Yeah.
Like all the doctors have been trained, thousands of doctors and professionals, and everyone that's come up. You've got to change the payer system, which is the government and the private payer system, and you've got to change human beings.
Yeah.
So you change who we all want the
Easy
quick
stuff.
fix and the easy
a week
thing,
or two to figure that out.
and not to have to go, throw myself in a cold plunge and then go for a long, hike in the mountains when you can just give me a pill.
Yeah, right.
And then I can just watch, Netflix and not have to worry about it. So to change all those three things is brutal. And you're thinking about how to, obviously you're thinking about the payment system. You're thinking about the human being that you're working with, and you're thinking about your own training and how you evolve that. So you're hitting on all three of those.
Yeah, we're trying to. I mean, I think it's from a system standpoint. I mean, I'm not going to try to be the guy who's going to change the whole system of America.
But you're changing your piece of it.
Yeah, that's what we're hoping to do. Like right now, I mean, we're small. We're hoping to make a meaningful impact in the Treasure Valley, and I think this is going to be a trend line that's going to continue. I don't think this type of medicine is going to be niche or, super limited. I think it's only going to grow. It's going to become more cost effective. I think. I'm no expert on AI, but I think with the advent of AI enabling more mid-level providers to have more access to patients, I think it's going to be able to get out there more and more. Unfortunately right now, it is hard to make this super broad where it can be implemented across the United States en masse, but we're doing our best here locally and taking our experience and hoping to grow that and implement it with as many patients as possible. But it is exciting. There's a lot of challenges with the medical system. And I think there's a lot of frustration too from doctors, from patients, et cetera. And I think there's a lot of hopefully change to be had over the next years and decades. But yeah, we're doing our best here, at least locally.
I want to make sure I'm cognizant because these things go by so fast. I want to make sure we hit hormone replacement therapy.
yeah. We've got.
And I really with you just because I do think. Well, first of all, and you said it, when you first walked in here to me, one of the first things you said is, hey, we got to make sure that the main things that people need to hear today are exercise, strength training, sleep. Yeah. Those are the biggies. Yeah. That's where you major in the majors, right? As Peter Tia says.
Oh, yeah, exactly.
And then minor in the minors. But the minor things do matter. And I think that there's a lot of information, maybe misinformation. What I appreciate about you from our first interaction is you're very science-based and you're not going to, the latest trends and tricks you're not chasing. So can we talk about hormone replacement, supplements, and then peptides? Those would be kind of three I really want to hit with you.
Yeah, let's do it. I'm just going to, if you don't mind, I'll list the 6 things that we focus on primarily, just so we don't. I keep going off into the weeds on each one.
Hey, when we were together for our first hour and 15 minutes, I don't think I got to all 6 because he would get to 2 and then I would interrupt him and So I'd love to hear 6 for the first time.
Yeah, let's do that so I can get that out to people. I just keep rambling. It's just such interesting stuff. But so we've talked about coronary disease. We've talked about metabolic health. Hormones would be a number 3. Probably more evidence for longevity on female side, but we'll get into that. And then cancer, early cancer detection is really important. So there's been some advents. We've gotten a little bit better, but there's still some strides to be had. We try to implement some new technology when we can, go a little bit ahead of the curve of the standard recommendations where they are at now. But cancer detection is really important. And then strength, like you said, strength and exercise, drastically important too. So that's our main 6 that we focus on. A lot more other than that, but to make it concise, those are the big buckets that we think need to be filled before we start looking at other things.
Great.
But like you said, I think that's a great quote. And I don't know who initially said it. I think I've heard Peter at DSA say it, but major in the major, minor in the minor is so true. And so if we don't have our house in order, there's no point to get into like the experimental supplement that may or may not have made the elegans worm live 20% longer.
Right.
Like, I don't know.
Rapamycin, gotta get it, all of us.
Yeah. So, it's really easy to get into the weeds, and then you're like, wait a second, I'm like eating a cookie at, at lunchtime, and then my hemoglobin
or at 9:30.
Yeah, or 9:30. Yeah,
before I go to bed.
Yeah, exactly. Tis the season too. But yeah, we can talk about hormone replacement for sure. So, it's an interesting topic, and I think it's gotten a lot of more attention over the past couple of years, but really over the past year, I've noticed it on podcasts that I may listen to and stuff like that. You hear a lot more about it, specifically the female side of things. But for a long time, it's been relegated into like the taboo, and the backstreet deal kind of feels like a little sketchy. But there's been so much data, robust data, that's come out from the male side and female side that suggests that these interventions are very safe and provide significant benefit. So I'll start with the female side of things. So since I think it was 1993, the Women's Health Initiative came out that looked at hormone replacement therapy. At that time, it was equine estrogen, so from a horse estrogen, and synthetic progesterone. That study came out and said there was an increased risk of breast cancer for females that were on that. And so from the 90s up until the past couple of years, it's pretty much been off limits. Unfortunately, females
Wasn't the black box warning just removed?
Just
like within the last 60 days.
Yeah, right. Like legitimately within the past couple of months. So, just a couple of years before that, there was the talk that, more studies coming out saying, hey, like, I think this, or the data would suggest that this fear, this increased risk of breast cancer or other cancers was unfounded. And so, fortunately, that's changed and had a lot more access to females for hormone replacement. So there was kind of new trials that looked into the WHI as far as the risk for breast cancer goes, and the relooking at the data actually showed that the estrogen-only group, even though it was not the estrogen we use now, so equine estrogen, actually had a decreased risk of breast cancer. And about a 30% decrease all-cause mortality for females that were on estrogen. And so over the past 30 plus years, we found through more research that there's basically estrogen receptors in every cell in the body, or every organ system in the body. And so when we go off that cliff in our late 40s or early 50s, estrogen goes to near zero. Same with progesterone. We know that affects muscle mass, that affects bone density, that affects cardiovascular health, brain health, et cetera. And so there's a reason why cardiovascular events for females actually increases in their 50s and beyond, as opposed to males, which are way outstripe females as far as risk for cardiovascular disease before that.
In the 30s and 40s.
Yeah, correct. And the same with dementia, et cetera. And so for most females, hormone replacement therapy is a very safe intervention. There's still a little bit of caution about females that have a history of estrogen receptor breast cancer in the past. But aside from that, using a low-dose estrogen, and if you still have a uterus, a low-dose progesterone, proven very safe. And then the addition of some testosterone can be helpful for some women as well. Getting that up just between 20 and 50 nanograms per deciliter, so not a huge amount, can be really helpful with muscle mass. So that's kind of our playbook for females. And now we call it, instead of just hormone replacement, we call it bioidentical hormone replacement. And the reason we do that is because it actually is bioidentical. So this the estrogen that we're administering is not a synthetic or an equine estrogen. And the progesterone is not a synthetic progesterone, it's a natural progesterone. So very well tolerated. And generally for most females, an estrogen patch, an oral progesterone at night, and a topical testosterone, those three of those things will work wonders for energy, for mood, for muscle mass, for cardiovascular fitness, dementia risk reduction, bone density, et cetera. So proven safe, decreased mortality benefit from estrogen. and pretty easy to implement. So fortunately, we've seen a big
Yeah.
uptick in the utilization of that. For males, testosterone replacement therapy has been a hot button topic for many years. And we've seen a big push in the, I guess I'll call it the industry. I wouldn't say the medical community per se, but the industry of testosterone. And so, there's been a lot of data looking into hormone replacement therapy for males as well. So there was the Traverse trial in 2023 that showed no increased risk of coronary artery disease, because there was always this black box warning or risk that testosterone was going to increase your risk of cardiovascular disease. They're actually talking about taking that one off as well. So that Traverse trial in 2023 said that there was no increased risk of cardiovascular disease. And then there's been other trials, and the Endocrine Society actually says that there's no real increased risk of prostate cancer. So we know that it's a safe intervention. We know that testosterone levels for males have generally declined over the past several decades. We don't have a really good answer on why that is, whether that's
Do you have any theories on that?
I think it's probably multifactorial. I think, if you look at, we talked about metabolic health has gotten significantly worse over the past 50 years. We used to be a pretty active, very slim society. We're now a very inactive, very obese society. And so I can't imagine that, excess obesity or adiposity doesn't play a role into that. Yeah. That's going to increase the aromatization or the transfer from testosterone.
Adiposity just means you're fat.
Yeah. It's the nice scientific way of saying you're a little rotund.
It sounds so much better, though, doesn't it, Andy?
Yeah, but like most things, what you're saying, doctor, is, I can give you a shot or a pill or a patch. Yeah. And there may be a time when that is absolutely correct.
Yeah.
But let's start with getting you out and walking, getting you into a place where you're lifting something.
Oh, yes. Good sleep,
that's
good
a little bit
metabolics.
like get your sleep, stop eating, junk food 3 times a day, et cetera. So all of that stuff,
hit on that, because
comes first, and then we, instead of what our, often we're sort of bombarded with, which is, do whatever you want. You grow that adiposity, and I'll give you a pill at some point, and
because
it's an Ozempic, it's a whatever it is, and those have their place. So I don't diminish that. We should, great minds in medicine are thinking of how to use this for someone with a type 1 diabetes, or how to use it for this. It's when we say, well, do that instead of the basics, the majoring in the majors, that
and
I think
all
we
of
mess
those
up.
things, the majors all increase your testosterone.
Yeah.
Strength training
without even putting
exercise,
without the patch.
sleep, right?
Yeah.
I mean that.
It's
So start there first, then we look at once you've built that back up, then we'll look at whether we need to supplement on top of that.
Exactly.
Yeah.
So that's what I kind of alluded to initially. There's been a huge uptick in clinics that specify in just testosterone. That's like what they do.
There's been some really interesting news stories. Wall Street Journal did one about 2 years ago, as I recall, about a bunch of clinics down in Florida, and they weren't all ethically at the level that you'd want them to be, and there are risks when you don't have trained medical professionals that are doing this based on scientific protocols.
And I bring that up just because I think it's Charlie Munger said, "Show me the incentive and I'll tell you the outcome." Hey, do you feel like, are you feeling a little run down, like low libido, we can make that better for you. And so, if the endpoint or the goal is to get as many people on testosterone as possible, because that's how we make our money, they're going to put you on testosterone.
Yes.
And so there's been a huge uptick in males, predominantly younger too, which is the scary part, that have been gone on exogenous testosterone that may not need it. So if you do a one-off testosterone on and it doesn't matter what the age is, but, let's say it's 300, 400, suboptimal, not technically low per se. Low would be under 300, under 250 even. If you don't test their LH and FSH that come from the brain, if you don't test their other markers, their metabolic health, everything like that, if you don't put the whole picture together, you can very easily be like, you probably will feel better with testosterone. Let's try it out. But if they're, from their brain, their LH and FSH is super low, then we know it's probably secondary related. So, hey, tell me about your sleep. It's 4 hours a night. Okay, there's one lever. Tell me about your diet, or like I can look at your DEXA and be like, hey, okay, metabolic health's not in line here. Muscle mass is low. Like, let's do some basic stuff. Let's get your vitamin D. Let's get your metabolics. Let's get everything in line. If we don't make strides on that, then yeah, okay. And you're still feeling a certain way. Let's talk about, other options for that. And so I did kind of jump right into the safety profile first, which probably should have started with this, what we just talked about. But safety profile is there when done appropriately. So all this safety data is male testosterone between 600 and 750 or so. Occasionally we'll shoot a little bit higher than that, 800s, 900s, but not really wanting to go much over that because there are risks, which we kind of alluded to.
Right, you go the other way.
Yeah, so you overshoot that. You can get erythrocytosis, which is basically an elevated red blood cell count, which, if you start getting over a certain level, a hematocrit over 54 or so, hemoglobin of 18, puts you at increased risk for stroke and heart attack. There's a potential for increased risk of blood pressure. So we want to track people's blood pressure over time. So we can help tailor that, strategy to where we're not getting to elevated blood pressure, having to put you on medication for that. And then prostate, we always follow your PSA. There's really no major link between prostate cancer, but we still want to track that over time. So if we're seeing a PSA velocity change, so no matter where you're starting, if we see a significant increase, we want to track that. Because if there was something smoldering that we didn't know about, and it does have a testosterone receptor positivity to it, there's a chance that it grows. But the overall link to prostate cancer is really mostly unfounded at this point too. But we check those.
You're talking about things between the PSA result and the actual cancer? Or what are you saying, the link between what?
Testosterone supplementation.
Oh, got it.
And
okay.
increased prostate cancer risk.
Yep.
But in a select individual who may have already had a prostate cancer we didn't know about, even if their PSA was low. But that's why we check it beforehand. I mean, it's pretty unlikely that anything that's going to happen. But
yeah.
But we want to be diligent about it. We want to make sure we're testing our levels. And so, we definitely don't believe in a set it and forget it. Like, let's say we've rolled out secondary causes. We've got metabolic health in line. We've got a strength training program. We, maximize our supplements. If we're not making any headway with that, we move forward with treatment. We're checking that, early on, even up to monthly, to make sure we're in the right level, and then going out to quarterly. And from there on, you can kind of space it out for not making changes. But we want to make sure we're in a good level where we're not causing adverse harm. That's not our goal here. So that's the hormone side of things.
Let me give you an intro to supplements.
Yeah.
So I do think for those out there who are majoring in the majors, doing all the things right, you're really tuned in now.
Yeah.
I think nutrition, I think the American diet, it's hard.
Yeah.
We know eating whole foods is the best thing to do and preparing our own meals.
Yeah.
But that goes without saying, right?
Right.
Fruits, vegetables, whole meals, whatever diet you pick, is if you're cooking it and you know what's going into it, that's the way to get nutrients, especially macronutrients. But then you hear a lot about, hey, in our diet, you also need these things. Andy and I talked in our first episode today about protein, how important that is.
Oh yeah, totally.
And so we hit that kind of heavily. That's one you should be doing. But then I do think, even though it's like this marginal increase in improvement, there's all this other, and that's, you follow the money and that's where it goes.
Yeah.
There's a lot of stuff out there on supplements.
Oh yeah, for sure.
So I would like you to hit on the ones we hear. I think omegas for heart. I think that's good. Vitamin D3 we hear a bunch about.
Vitamin D3.
Totally.
Yes,
Vitamin D3. I'd love to hear more about that. Magnesium deficiency.
Yeah.
I think there are some. I would say that almost everyone, especially older 50s and 60s year olds, should be taking. And I want to hit creatine. So I think if you could comment on those four biggies, and then in general what you would recommend. There's a whole bunch of other stuff that's out there, but I think those are the big ones.
Yeah, I agree.
And D3
K2.
with K2.
Yeah, with K2.
And talk about why that matters, because I think the last couple of years people really started to understand that, and 10 years ago they were just taking D.
Yeah, right. Yeah, I wholeheartedly agree with that intro to supplements for sure. So our main approach is pretty backed by data, and the main ones that have data behind them, omega-3s like you alluded to, D3, K2, creatine, and then we bring in methylated B vitamins for certain people that may need them. So
do you do do you check methylation as part of your initial screening for all your patients?
Yeah, so indirectly. So there's a genetic way of doing it. You can test people's MTHFR gene, but you don't really have to. If you test someone's homocysteine level.
Yeah.
I love it when two doctors talk. So methylation, and whatever that means, you're testing.
So the way your body metabolizes and breaks things down.
Yeah. So methylation is just like a single carbon group, but adds a little tag to the vitamin, makes it an active form.
Yeah.
The body utilizes it, if I'm remembering my basic science correctly. Some people genetically don't do that well.
Okay.
And that can lead up to a buildup of a certain protein called homocysteine. Homocysteine can be hyperinflammatory, and then you're just not utilizing your B vitamins well. And so you can do an expensive genetic test and test your MTHFR gene, and there's several other lists of genes in there. Or you can test your homocysteine level, which is a pretty cheap $15 test or so. If that's elevated, you're pretty much guaranteed to have an MTHFR gene mutation. And so that's a supplement that we don't recommend just universally, but something that we bring in based on our testing. If people's homocysteine levels, let's say greater than, we like it around 9 or less. If someone's like 10, 12, 13, 14, 15 beyond, then we'll integrate that. But yeah, to get back to the big one. So omega-3s for sure. So most people, I think as a blanket statement, you could say 2 grams of omega-3s is unlikely to cause harm, very safe. Most people need it. Most people aren't.
So I want to hit this dosing for people.
Yeah.
So 2 grams of omega-3s.
Yeah.
And does the source matter on that?
Yeah. So more often than not, we're doing fish-based. There are vegan options. There are krill options. But mostly we're doing fish source. I should have brought the list of the 3 or 4 we recommend because, of course, I'm going to blank on them now. But there are third-party verifications where they look at the tox levels of them. They look at the purity and the oxidation levels. And so we've gone through that data and come up with 4 or so that work out. And of course, I'm going to blank on it. Maybe we can put it in the show notes or something like that.
Yeah, we can put it
But about 2 grams is a good place to start.
Okay.
We generally will test people's fatty acid index or balance. A pretty simple test. We can see your saturated, unsaturated trans fats, and also your fatty acid index. And so there's some good data out there that suggests that having a fatty acid index, so what percentage of the cell membrane is made up of DHA and EPA, which are those unsaturated fats, having that at or above 8% has about a 30% decreased mortality rate.
Wow.
Compared to being in the low category. I would say based on, anecdotal data or limited data from our clinic, most people fall into the low category unless they're already taking 2 to 3 grams per day or eat a significant amount of fish in their diet. And so supplementing up to that point is good. So best case scenario, we have a pre and post intervention test to know where we're at to guide our treatment. But in general, most people are going to do just fine having about 2 grams of an EPA DHA supplement per day. And then we'll link in the show notes those ones that have a low tox, low oxidation level, and a good purity level without arsenic and all that stuff in it too.
Fantastic.
So that's omega-3s. Vitamin D, I don't think, we're probably like 80+% of people we test are low for vitamin D. Occasionally we'll have people that are high that are following maybe some bad data and taking 10,000 international units a day or something like that. But most people are low. And so a D3K2 supplement is what we recommend. Having that combo really helps with absorption and utilization.
And you'll dial in the amount probably based on your patient versus just saying everybody should take X.
Yeah, so this is one of those supplements where you can't really in good faith say like everybody should be on this amount because occasionally you do. People that are in just fine levels don't need it or it can get toxic. If you get your vitamin D level up too high, it's a fat soluble vitamin. You don't pee it out. It's one of 4 the last I checked. And so you can really easily get toxic if you're taking too much. And that's where I've had a couple people come in just taking these massive doses. Their calcium's high. They're at risk for kidney stones, et cetera. So it's one of those supplements that we recommend most people be on, but we generally recommend people get checked prior to it instead of just blanket taking it. Especially, if you're a dark-skinned individual living at northern latitudes, which, Boise is, like, you're pretty much guaranteed to be deficient. Vitamin D is really helpful. Bone health is what we think about it for, but also immune function as well. It's kind of taught and labeled as a vitamin, but it's really more of a hormone, really. It's a fat-based kind of cholesterol-looking molecule that has a lot of different functions throughout the body. So vitamin D is a big one. Creatine is one that I feel like in high school it was just like the gym bro thing to like take some creatine.
Yeah.
And that's what you did. Got a little pre-workout with probably way too much caffeine and had some creatine in it. But Some pretty interesting data about creatine for not only muscle mass, but some new stuff coming out about cognition. I think it's all, it's a little bit on the small side of data, so not robust per se, but some benefit between 10 and 20 grams of creatine for cognitive performance.
I was going to ask you. So I think there's a lot of data I've been reading about, and it seems, it seems like, and also I think the elevated creatinine level in your blood would make you worry that you had kidney problems. But I think that's probably been falsely
put out there
for a while.
It's our biomarker. It's the problem with the biomarker, not with the supplement per se. So, a standard kidney function test is going to include, a couple different things, but your BUN is the one blood test, and then your creatinine is another one. And so by taking exogenous or, taking a supplement of creatine, that can falsely elevate that test. Yeah.
What dose do you, because the one thing I haven't heard clarity on for someone in their 50s that are thinking about taking it for the cognitive kind of preventative benefits of the brain health and muscle mass.
Yeah.
Do you do 5? Do you do 10? Well, what's your number?
If someone's not on creatine, I'll usually say start with 5.
Okay.
Get them used to taking it, get them, make sure they're not having any GI side effects. One of the main side effects would be some GI distress, a little bit of bloating, occasionally diarrhea. Other than that, it's pretty well tolerated. And then if they're tolerating that, then we'll bump it up to 10. That's where we sit most people. Occasionally, if people are, really looking to optimize, they'll shoot up to even 15 or 20 occasionally. I think some of the newer data is between 10 and 20 grams of creatine for brain cognitive function. Generally, the muscles are pretty greedy. They eat up most of that creatine. It's why it's important for muscle is it's a phosphate donor, and so it helps with ATP, which is the energy of the cell, if you will. And so it can increase energy output of the muscle cell, increase the total volume of weight lifted. So by proxy, then can increase your muscle mass. And so that's where it first came into being of why it got popularized, because it did show an increase in your muscle mass, partly due to the fact that it does bring some water weight into your muscle too. So it increases that kind of pump feeling, if you will. But it can increase the maximum output that you're doing in the gym, which can improve muscle mass, which can help your insulin resistance and insulin sensitivity and bone density and et cetera, et cetera. So I think it's again, it's, we got to have the whole house in order. But creatine's a good adjunct there for muscle mass, and then some new interesting data about the cognitive side of things. But yeah, I'd say 5, then I'd get up to 10. And then if people want to push it, I think there's really little downside to going up to 20 milligrams or 20 grams, I should say.
And the one question I had is kidney thing.
Yeah.
You think that, so if I've been on 5 for a couple of years, like I have, I go to 10, and I get a little bump in my creatinine on my blood test. Yeah, that's normal. It's not nothing to worry about.
No, if there's any concern, if creatinine, I should say, is going up with supplementing creatine, we'll do a cystatin C test, a little bit more specific testing for the renal function, and then as long as that's in line, we don't care what the creatine or the creatinine is. So. Yeah, and then, those are the main 4 really. There's been some evidence of a standard multivitamin for people over 65 has been shown to improve, not really longevity, but improve some cognitive markers and functionality as you age. So we'll implement that. For the general public, I don't think there's a huge benefit from just a standard multivitamin, but really low downside as well. So pretty low-hanging fruit to consider it, especially as we age. And then there's 4 or 5 kind of interesting, I would put them in this kind of weak data, but interesting category. Those are, 1 of 4 here. So NAD is interesting. It's got some good data, some meh data, mostly animal. So there's different ways to supplement that. So NAD is a molecule that leads into NADH, which is basically an energy carrier in the cell. We know that NAD levels go down as you age. And by, supplementing that, there's been different companies that come out with different formulations that have been shown to increase your NAD levels. We just don't know if that really leads to any downstream outcomes. There's no data to say like, hey, your NAD levels are that of an 18-year-old. You're going to live, X amount of years longer.
Right.
It's pretty limited. So there's different ways you formulate that. So NAD, there's new formulations where it's liposomal. They put it into a fat molecule so it can be digested and uptaken pretty quickly because it is a molecule that, can
So you're basically taking the precursor and then it...
Well, these liposomal formulations is actually the NAD. It's just
itself. Okay.
Yeah, it's just contained in a way that it's better metabolized. Because otherwise, if you take just NAD, an oral supplement or sublingual, even it's gonna switch over into its oxidized form and not be really utilizable in the cell. So there are precursor molecules like NMN and NR,
which have been around for a while.
Yeah, exactly.
In use.
Yeah, there's some interest, I think, more on the liposomal NAD, the NMN, NR. Again, if the house is completely in order, we're 65 plus, and I'm throwing 65 out there just very vaguely, but it's something we could consider adding. Resveratrol, kind of a polyphenol type molecule found in berries and such, has some benefit for senescent cells or cell turnover essentially. It's very preliminary data. Who knows what the long-term outcome will look on it, but something that we look into and discuss with clients, generally again on the 50s plus. I'm not going to recommend that to a 35-year-old per se. Urolithin A is an interesting one. Has been shown to improve mitochondrial function. So we have some, there's some data out there of mechanistically that this should improve mitochondrial function, help with senescent cells and cell turnover. We just don't have any actual data that it improves any outcome, but some interest out there in that one. Spermidine is another one as well. Some mechanistic data that should improve mitochondrial health, et cetera, but just no real data on true outcomes for humans.
It's so interesting to me how often people are talking about mitochondrial health now, everywhere. It's like it's like
it's such a buzzword.
It just has become these things catch on.
Yeah,
and now all of a sudden that's all everyone's talking about. That's very helpful.
Yeah,
I can't believe our time went by so quickly. I'm gonna throw one more in there.
Yeah.
So when I was in medical school, we were in anatomy, and someone had methylene blue, and there was a brain there.
Yeah.
And I remember being shocked when the brain was like literally dyed blue.
Yeah.
And so now that that's become a thing now, I can't imagine as a physician ever putting it in my body after seeing on a cadaver what it did.
Yeah.
But it like people are doing this. So where do you stand on it? For me, seeing it, I'm like, anything that dyes my brain like that, I don't want to have anything to do with.
Yeah. I was and maybe am a little skeptical. My one experience with methylene blue was in the ICU in residency, and they had used it in a refractory hypotension case because it was like sixth line that you could use for hypotension or low blood pressure. And they gave it to an individual who I think was taking another selective serotonin reuptake inhibitor or like an SSRI, antidepressant kind of medication. They developed serotonin syndrome from it, and were like, super rigid. Their temperature was like 104. Anyway, so that was like my one experience with it. And I was like, why the heck would we give this to healthy people? But there is some data out there that suggests that it, may have some benefit. I'm kind of on that, like, I want to learn some more about it.
RFK Jr. is like passing out like shot glasses of it in Air Force One. And I'm like, man, I don't know about that.
I don't know. Yeah. I think it's one of those ones I have in like a short list of like kind of following. I think the wellness community has definitely jumped on it. You pull up any IV clinic, they're probably going to have methylene blue in there. It's popularized.
Yeah.
I don't know. There's a lot of interesting stuff in the wellness community too, like ozone, adding ozone to your blood. Like they'll basically pull your blood out of you, run it through a machine, add ozone, put it back into you. I'm like, I don't know, man. I don't know. It seems a little bit out there. Or like detoxifying your blood. I'm like, I'm pretty sure your kidneys do a pretty good job.
Yeah.
We put people on dialysis when it's at the worst case, but I don't think, a healthy person just go get dialysis for fun.
And the one I heard the other day is like the microplastics. Like they'll basically do put you on dialysis and run it through this thing. And I just don't know. I think we got to be. Listen, I think a good place to end is I think we stuck with kind of bread and butter today.
Yeah.
like really science proven.
Yeah.
Again, major in the majors, the things that we know matter, and then once you get there, these are other things. But also be a little bit skeptical.
Yeah.
Until there's data that shows. And that's why I like Peter Attia. There's a lot of people out there, but I think some of them clearly follow trends, and I think he seems to be, at least in my view, one of the ones that really tries to science back things.
I agree. And you know, with the advent of social media, you know, there's just so much out there. And since opening a business to having a business account, and it's like all I get is healthcare related stuff into that one. And if I find myself on it, I'm like, oh my gosh, like what it, you know.
And what I love about your presentation today is there is so much well established, meaningful, principle-based approach, you know, just that going way out on the edges, at least for those who don't have a really unusual, unique symptom or situation. Why?
Yeah,
because there's a lot that you're doing. You're testing for stuff that really has been proven to make a difference, and then you're providing a protocol for that for a patient, and then you're testing them again to see how is it doing, and then you're adjusting based on that, and you've got a whole menu of stuff that we know works and that we're not doing already. So why not do that first?
Yeah, there's very few people that come in with their house completely in line. They're like, "Dang, you're doing a great job." Like, I no notes. I don't have anything for you.
Hey, compare no notes to when I was with him. He was like, "Oh my gosh, oh my gosh." Hey, let's end with. Can you pull up his website here? What's your URL?
It's peakhealthidaho.com.
Peakhealthidaho.com. Super easy to navigate, by the way.
Thanks.
I got on and did it. You did a nice job.
Appreciate it.
Again, you're here in Meridian, right off of the Eagle Road exit.
Yep. Eagle and I guess it's Overland. I should know that. I drive it every day.
Yeah. Yeah. Well, Eric, this has been great. So Peak Health Idaho. Thank you so much for coming on today. And
absolutely.
Look forward to having you fine tune me.
Yeah, absolutely.
And appreciate you sharing with the community.
Anytime. Happy to be here.
Excellent
had a fun time.
presentation.
Thanks, everybody.
Absolutely.